Continuing on and starting off with vasculitis, vessel wall inflammation. We know that vasculitis is a group of disorders that destroys blood vessels by inflammation, and both arteries and veins are affected. But here we're going to start off by discussing Polyarteritis Nodosa, or PAN, and this is a systemic vasculitis of small or medium-sized muscular arteries. And what are the symptoms of vasculitis? Well, they vary, but you could have low fever, weight loss, malaise, hematuria, renal failure, hypertension, abdominal pain, diarrhea, GI bleeding, myalgia, and arthralgia. So this is just a very, very basic overview of vasculitis. Let's talk about the pathology of segmental necrotizing vasculitis. What are the stages? 3 stages. First, A, acute fibrinoid necrosis and neutrophils. Second, healing fibroblast proliferation. And 3, healed lesion nodular fibrosis and loss of internal elastic lamina. So we're talking about polyarteritis nodosa. Okay, so let's move on to heart failure. Well, this is just a very quick overview. We're not going to talk a great deal about heart failure or CHF. This will be discussed in the system-based modules, but generally we just need to recognize left heart failure, the etiology of left heart failure, understand the basics of ischemic heart disease, hypertension, myocardial disease, aortic or mitral valve disease, and consequences here. So you might have an increased heart rate and left ventricular hypertrophy and dilation. And then, of course, heavy edematous lungs, and this due, of course, to backflow and osmotic pressure. Then, of course, we have ischemic heart disease, which we also need to know the details of, which we can do in our reading. But just to summarize here, we should know that it is usually secondary to coronary artery disease and the most common cause of death in the U.S., most common in middle-aged men and postmenopausal women. Angina pectoris, transient cardiac ischemia without cell death resulting in substernal pain. So it presents, and myocardial infarction is the result. And we have a localized area of cardiac muscle necrosis due to ischemia. So what are some of the syndromes of IHD? Angina pectoris, stable or unstable, myocardial infarction, MI or AMI, chronic IHD, CHF, or sudden cardiac death. And then we have acute coronary syndrome such as unstable angina, AMI, or sudden cardiac death. And how about IHD risk? So we, number of plaques, distribution of plaques, size and structure of the plaques. So we're not going to discuss the details here. We can read about that. But we should understand the basic progression of myocardial necrosis following coronary artery occlusion. So we should know that the necrosis begins in a small zone of the myocardium beneath the endocardial surface in the center of the ischemic zone, but the area depends on the occluded vessel for perfusion, which is at risk. Note that the very narrow zone of the myocardium immediate beneath the endocardium is spared from necrosis because it can be oxygenated by diffusion from the ventricle. You cannot see this picture here, but it is quite clear. We can understand quite clearly the zone of perfusion and the complete infarct involving nearly the entire area at risk. So remember this picture clearly. So moving on, we're going to talk about some of the microscopic features of myocardial infarction and its repair. You cannot see the pictures here, but I need to remember the basic process, looking at the histology. There may be slides on the test, I don't know. 1. A 1-day-old infarct showing coagulative necrosis and wavy fibers. And we should notice that they are elongated and narrow as compared with adjacent normal fibers at the right, and widened spaces between the dead fibers contain edema, fluid, and scattered neutrophils, which is what a pathologist would notice. So they are starting to, the protein is starting to denature. And we should notice that at the beginning, after 1 day, you're going to have polys or neutrophils there trying to help out. So we would have, at 3 to 4 days, we'd have dense polymorphonuclear leukocytic infiltrate in the area of acute MI, and this is for 3 to 4 days. So I can see those clearly, the polymorphonuclear leukocytic infiltrate. And then there would be nearly complete removal of the necrotic myocytes by phagocytosis after approximately 7 to 10 days. But then you're going to have scar tissue and empty space because all of that died. So that's quite clear to see. And then we have granulation tissue, which is characterized by loose collagen and abundant capillaries, which I can clearly see and remember. And then it would be replaced with connective tissue. So we have a well-healed myocardial infarct with replacement of the necrotic fibers by dense collagenous scar, and a few residual cardiac muscle cells are present. Okay, I can see that. And finally, let's discuss basically valvular heart disease and rheumatic heart disease. In valvular heart disease, we have degenerative calcific aortic valve stenosis. This is a common valvular abnormality, age-related dystrophic calcification, degeneration, and stenosis of the aortic valve. And it is common in congenital bicuspid aortic valves. It causes concentric left ventricular hypertrophy and CHF. How do you treat it? With aortic valve replacement. How about rheumatic heart disease? This develops a few weeks following a group strep A infection, strep A infection. And the rates of rheumatic heart disease have decreased in developed countries. But just remember that it is following a group A strep infection. And the antibodies to strep would recognize the proteins and cause a lot of problems. So, I know you guys think I'm crazy, all 5 viewers of you, but this is the way I remember slides, this is the way I remember books, by speaking them out. It's actually quite easy to remember if you have an image and you have a voice to go with what you're saying. It's quite easy to remember when you see an MCQ. Anyway, rheumatic valvular heart disease, bullet points. Pharyngeal infection with group A beta hemolytic streptococci, systemic inflammatory, and the infection results in production of antibodies that cross-react with cardiac antigens. We've talked about that before, as they are similar to our own proteins. Myocarditis, pericarditis, endocarditis, chronic rheumatic heart disease can damage the mitral and aortic valves. If that's a question, better remember that it can damage both the mitral and aortic valves. So there you have it. Good luck on the test.